evening, everyone. My name is Dr. Rishi Sani. I'm actually the medical director of the Stanford ValleyCare Cancer Program and Services. On behalf of the cancer program and Stanford Healthcare ValleyCare Administration, I would like to welcome you to the 9th Annual Breast Cancer Symposium. It's hard to believe that this is actually our 9th year already. At Stanford ValleyCare, we are very fortunate to have a breast center of excellence. Our breast cancer program is nationally accredited by the National Accreditation Program for Breast Centers. We've been accredited since 2011. And the type of services we offer are comprehensive services. So right from screening to diagnosis, multidisciplinary breast cancer care, which is, whether it is medical oncology, surgical oncology, radiation oncology, clinical trials, and then what happens to the patient after they're done with their intense cancer journey, and that's survivorship and even prevention. At our breast center, the mantra that we've had is we are not here to treat breast cancer or a breast. We are actually here to treat a person who happened to have breast cancer. So it's this sort of total person or the total person approach that also has allowed us to bring a lot of integrative services to our patients. Many of our patients enjoy non-medicinal interventions, including acupuncture, acupressure, therapeutic massage, guided imagery, yoga, healing touch. All of these to not essentially replace what we are doing, but actually to complement what we are doing and to minimize side effects from the treatments that we are giving them. So many of our partners and nonprofits are out there in the estate room, so I encourage you to sort of mill around them and thank them for their generous support of the cancer program. This cancer symposium is part of that commitment to the community that we've had. Our goal has been to spread breast cancer awareness. October is Breast Cancer Awareness Month, so we've sort of held this program every year over the last 9 years, and it's grown from actually 20 attendees and 3 physicians in a small classroom in the cancer center to this beautiful venue with over 150 people tonight. So I want to thank you all. We are privileged to have all of you from the community attending. And we're also very privileged to actually have a great panel of speakers, distinguished panel of speakers tonight who will be educating and enlightening us while you all enjoy some wine and hors d'oeuvres. Make sure you've gotten your wine glasses filled. So before we begin, I want to actually thank a couple of individuals and organizations that have actually made tonight possible. Without their support, we won't be here. In terms of individuals, I would ask Denise Estrada, Sherry LaSalle, and Lee Teckel to stand up. Lee is still working the table. So these 3 individuals are kind of the bedrock of getting this whole event tonight together. I want to thank the committees of our breast steering committee. They are sitting on the table up front. Their support and their direction to our breast program has always been important. I want to thank the Stanford Healthcare ValleyCare Administration, CEO Scott Gregerson, COO Tracy Lewis Taylor, and the marketing department, diagnostic radiology, nursing, ancillary staff. All of these people have made a huge commitment to taking care of our patients and enhancing the cancer program. So thank you very much. And finally, I would like to thank our sponsors. A special thanks to Tri-Valley Sox. Tri-Valley Sox has been a huge supporter of this program. It is their advocacy, their fundraising that makes this night possible. So thank you so much. I would also like to thank our other sponsors, American Cancer Society, Amgen, AstraZeneca, Chemobag Ministries, Culinary Angels, Genomic Health, Hearst Breast Cancer Foundation, Hope Hospice, Lazarex Cancer Foundation, Marzell's, Sanjiving Healing Therapy Foundations, and University Healthcare Alliance, VMOC, all of who've sponsored the night tonight. Thank you so much. In terms of some housekeeping, the restrooms are to my right, essentially to your left, beyond those barrels. The format tonight is 3 speakers. We will have 2 speakers go first, then there will be a time for Q&A and raffle prizes. So I hope everybody's picked up a raffle ticket tonight. We actually really have some good prizes for the raffles. And then after that, we will have another session by Dr. McDavitt, and then some additional question answer session after that. So make sure you stay till the end, because I think our biggest raffle prizes are reserved for the late night. So without further ado, I would like to introduce our first speaker. We are extremely privileged and happy to host Dr. Suleiman Masavre, who's actually an associate professor of medicine in the Division of Medical Oncology at the Stanford University School of Medicine. He's actually the medical director of the breast cancer program at Stanford. He is also the leader of the breast cancer research group. His CV is about 60 pages long, but we have a distilled version of it that I will go through. Dr. Masavre specializes in breast cancer with a particular expertise in the adjuvant therapy of hormone receptor positive breast cancer, metastatic breast cancer, and male breast cancer. His research background is in the study of endocrine therapy, its action and resistance mechanisms, as well as targeted therapy to overcome it. His outpatient practice is exclusively dedicated to patients with breast cancer, and his philosophy is centered around providing his patients with compassionate cancer care. Cancer education and promoting clinical practice innovation is an integral part of his academic and leadership mission. Dr. Masavre is dedicated to healthcare transformation and using novel approaches to enhance integration of clinical care, research, and education that is driven by patient-centered design. So without further ado, I welcome Dr. Masavre to the podium. Thank you.
Thank you for that lovely introduction, and such a delight to be here. I have to comment on the amazing operation these guys have here, and most importantly, patient-centeredness. That's very evident from the work that they're doing. So I'm not sure if the one's going to speed me up or slow me down. We'll find out. So I'll talk today a little bit about some ideas about how we may want to treat breast cancer in the future, and starting maybe some basics about how we view breast cancer through the biologic stages of tumor development. So breast cancer starts from a single cell that is abnormal, of course, proliferates, divides, until to a point where it gets its own blood supply. And then breast cancer cells with the new blood supply have the ability to invade and disseminate to other organs. And that is the risk of developing metastatic disease. And metastatic disease is important because in breast cancer, as in other cancer diseases, it'll actually the potential to lead to mortality. Clinically, when we think of breast cancer, we think of breast cancer in terms of where is it localized as we see it. So stage 1 breast cancer is disease that is confined to the breast itself. Stage 2 breast cancer would have reached the lymph nodes. Stage 3 breast cancer is in those areas, but also has additional features such as advanced disease features, skin involvement, involvement of the chest wall, ulceration. And then when disease is outside the breast region, that's stage 4 breast cancer, when it is present in other organs. And at any one of the first 3 stages, breast cancer cells could be present outside the breast, even though we may not be able to see them. And the risk from having these cancer cells outside the breast in what looks like early disease is that these cancer cells can become seeds, and they can, with time, depending on the type of cancer, divide and get their own blood supply and become tumors in these other organs. And that would be stage 4 breast cancer. And what we would want to do is try to eliminate or contain these breast cancer cells that are out, and we may not be seeing them, to prevent them from being seeds and germinate and produce cancer outside the breast, because that is the risk of mortality that can happen if that would become the case. So this is the logic of the basic biology of breast cancer and the clinical evolution of breast cancer. So I'll tell you a little bit about my area of expertise, which is ER-positive breast cancer. That's my primary area. I am a breast cancer doc through and through, so I do everything, but this is the area that I started my research with. And ER-positive breast cancer happens to be just about 80% of all cases of breast cancer. And this is driven by estrogen. What estrogen does is that it attaches to the estrogen receptor in the cancer cell. It makes it activate and open up DNA. That's the building blocks of genomic material, and lead to translation of proteins that lead to growth, invasion, metastasis, and thus promote the cancer evolution process. And what happens is that when we treat breast cancer, we try to block this important key pathway driven by estrogen through what we call collectively as endocrine therapy. Hormonal therapy, anti-estrogen therapy, I like to call it endocrine therapy. It's basically trying to prevent estrogen from stimulating the estrogen receptor and driving tumor growth and metastasis. And there are many ways of doing that. The classic tamoxifen, anti-estrogen, and then estrogen deprivation strategies, the minus E2 here, which takes away estrogen from cancer cells, like in aromatase inhibition. And then some newer drugs that can block estrogen receptor and actually destroy the estrogen receptor. So these have evolved over the last 10 years, and we have expanded our options of treating this particular cancer and became more effective in doing so. But even though we are good and we are effective, despite the improvements, there are some issues, and the most important one is that regardless of what you use, therapeutic resistance remains as a key problem. Cancer can find a way around this particular strategy that you're using to block breast cancer. So if you look at a cancer cell again, what we find out is that it's not really an isolated signaling area with estrogen and DNA and where that happens driving. We know that there are other cancer pathways that are present in a cancer cell, and these can interact and stimulate breast cancer either independently or in collaboration with estrogen, and can promote cancer growth. And if we do not pay attention to those other pathways, then we would be partially treating the cancer or allowing these other pathways to escape and become the driver of resistance, the new driver of resistance. So basically, what we know biologically through the studies that we've done in animal models, also a lot of these have been translated to patient clinical trials, is that you may have to block some of these other pathways if you want to optimize endocrine therapy benefit, prevent resistance. And these are a variety of pathways. Some of them have been through many clinical trials, through drug development. A lot of them are therapies that are approved. The PI3K mTOR pathway is a classic one. The more recent CDK4/6 inhibitors, these are drugs that they inhibit further downstream at the core of the pathway. And all these have been under one name or another, different trials approved for treatment of patients with metastatic breast cancer, with cancer that's already spread outside, because that's where we start and we go backwards. So, and this will move into the early disease setting, and there are studies that are ongoing. But for now, would we know of any clinical markers that can identify and isolate this problem of resistance? And we do. This is a study that we just published earlier this year. This looked at breast cancer survival at 5 years in patients according to recurrence score. Some people may know it as oncotype. And basically looking at risk of disease relapse based on analysis of this 21 gene assay, so a little bit more of a deeper probe of what these cancer cells are doing. And what we found is that in patients who have a low to intermediate score, so from 0 to 30, some of you are familiar, the score is from 0 to 100, there's a low score up to 18, and then intermediate up to 30. If you're low to intermediate, the risk of mortality from breast cancer is extremely low. It is very treatable, and patients do very well. So prognostically, it's an excellent prognostic marker. But if the score is above 30, then there is a risk of mortality that's higher, that isolates this group specifically. And this is a relatively smaller group because the majority of patients will fall in the intermediate to low risk group. And what I can tell you here is that this score shows you this mortality risk and relapse risk regardless of nodal status. So this is in patients who have node negative disease or also node positive disease. Even if the cancer reaches the lymph nodes, this test shows the same kinds of finding. The interesting thing I would like to also point your attention to is that this outcome and this prognostic ability of the test, not just regardless of lymph node status, but also despite the use of chemotherapy. So if you notice, with higher score, patients get more and more chemotherapy. In high risk score, 31 or above, up to 70% of patients will get chemotherapy. But despite the higher use of chemotherapy, still there is a higher risk of relapse, indicating that there's something else that we are missing, and chemotherapy is not the answer. And this is very important because I want to show you that when you look at survival and break down the group of patients according to nodal status, so negative nodes, positive nodes, and then the whole group together, everybody together, you see that in that low to intermediate score group, and regardless of nodes, that they all look the same. The negative node, positive node, and collectively, patients will do well despite the presence of cancer in the lymph nodes if the score is up to 30. Once it goes higher than that, that's when we really need to start scratching our heads. That's when the problem of resistance becomes a real issue. So that speaks to the fact that breast cancer in the first 5 years can be resistant to treatment, and that's what happens. Now, what happens beyond the 5 years? Because the 5 years is a dogma that we always have to live with. And what we see is that there is another side to the story beyond 5 years. What happens after you stop anti-estrogen therapy, such as tamoxifen, and beyond that? And this study was recently published, and it shows from a large meta-analysis that's thousands and thousands of patients with known outcome up to 20 years after diagnosis, that once you stop hormone therapy, there is now a continued risk of disease relapse that occurs in the first 5 years, 15 years, 20 years, suggesting that this is not a very finite time. This is a lifelong illness. And these are patients who are no longer on treatment, right? So you look a little bit more closely, and you found that the highest risk for this to happen, disease to relapse beyond pill therapy, is in patients who have positive nodes. The more the number of nodes involved, the higher the chance of relapse, indicating maybe that there is a higher quantity of disease present. So when we look at resistance, and this is something that is not immediately apparent to a lot of people who study this disease as well, we have to think of breast cancer that depends on hormones as one of two problems. One is an early problem in the first 5 years where we get, or shortly thereafter, where we get disease resistance to therapy. And that's a separate problem. And then a problem that has to do with us not doing a good job of continuing treatment to the extent that the patient needs it to prevent later relapse, because later relapse is a big problem, and we cannot call that resistance. We should call it inadequate therapy. This is us not doing a good job maintaining those patients on appropriate therapy for the long time that they need to have that. So this is a premature withdrawal of anti-estrogen therapy, thinking that we've actually fixed this, but we actually did not. So I'll go back and qualify my statement that I said earlier, that even though endocrine therapy or anti-estrogen therapy has come a long way and improved substantially, we know that the major problem to any form of anti-estrogen therapy is resistance. But I will add to that, and the fact that we do not optimally treat patients and keep them beyond the time that we need to do to control the disease. So we need to extend therapy. And there are a lot of situations, we don't have to extend therapy in everybody, and we don't know exactly every patient who needs to extend therapy, but there are certain things that we should pay attention to where we should not stop therapy too soon to minimize the chance of developing metastatic disease. And there are certain subsets of disease that we should do that in. Now, having said all this, and I showed you data that looked at clearly long follow-up, clinical trial data, have to do this for years, you have to have thousands of patients. Let's talk a little bit about the logic of breast cancer and see if we can do things a little bit differently. So this is kind of the futuristic part. Despite the fact that treatment has come a long way, and we have major advances in systemic therapy, we do have some deficiencies, and these are significant, and mostly in our understanding of disease biology. Strategically, there are three key issues that we have to solve, and we have to think of it this way. One is to understand and know what is the appropriate duration of therapy in sensitive disease, what I just shared with you right now. Because that should not be a resistance question. This should be an appropriate quality of care aspect that we should be able to do. Number two, over-treatment. Despite the fact that we actually undertreat some patients and don't give them therapy for long enough, we tend to over-treat otherwise, believe it or not. In breast cancer, we tend to throw the kitchen sink sometimes. And that is not okay. We have to be able to identify when enough is enough, and we don't know how to do that quite yet. And the most important problem that is not fully identified right now is the problem of therapeutic resistance. How do we find out who these patients are who have resistant disease and make a pivot, take them out of the bucket and do another bucket to attack the problem of resistance in those patients? And this may not be the biggest problem, but we need to isolate that problem and attack that problem effectively. Now, this is not something that we do or think about often, but the risk of disease relapse eventually may depend on a more dynamic tumor view. So, how does the cancer interact with therapy? Do we know that? And most of the time we actually do not. Pill therapy in ER-positive breast cancer, chemotherapy or antibody therapy in triple-negative or HER2-positive breast cancer. We do not know how to do that because of the dogma that exists. And the dogma is that when we look into the future of breast cancer, we can't really see far enough if we continue to do things the same way. We have a very static view of breast cancer. We take the cancer out, and then we basically arrest it in whatever stage it is, and now we think that we have all the markers we need to alter the natural history of the disease. That is a very static view of breast cancer that's not going to work anywhere. It may work for the majority of patients who have sensitive disease, but it's not going to work for solving the problem of resistance, which is what we really need to focus on. We cannot, in that context, afford to keep doing big studies with thousands of patients and wait 5 to 10 to 15 years to know outcomes. That doesn't make sense anymore, because we are using time, effort, money, and patience to answer a question that may not even be the appropriate question. So we have to think about the dynamicity of the disease and how we can interact with the cancer and have the therapy interact with the cancer and identify this dynamic interaction early on. So preoperative or neoadjuvant therapy of cancer can help us understand how the cancer interacts with treatment. We can get information about pathologic response, which is something we do in practice. We can look at proliferation, how the cancer divides, if it's ER positive, for example, and we look at these as short-term endpoints to correlate with outcome and validate these endpoints. We can then get more information that would be more than what we would get from the adjuvant or after we remove the tumor and we treat blindly, because then we don't know. We're just shooting in the dark most of the time. So for clinical trials, we need to learn about redefining our strategy and endpoints. How do we select higher risk tumors? We don't need to do clinical trials in the patients who are doing really well with no risk of resistance. We need to do clinical trials in those patients who have the highest risk of resistance. And we have clinical identifiers like oncotype, like a recurrence score to identify those. We need to study residual pathways that happen after we start on our backbone therapy. Identify new targets, personalize for every patient what's happening in that particular cancer, and think also in terms of multiplicity and be more long-term, because there's not one thing that's going to be the answer. In one patient, things may evolve, and we should be able to evolve with that to understand how cancer behaves in the long term. And the way to do this is, instead of doing these cumbersome, long, expensive clinical trials, that we have to incorporate this research mentality into our practice. We want to do this routinely in patients. I say that every time we take a tumor out surgically without interrogating that tumor, we kind of shoot ourselves in the foot. We need to investigate the cancer while it's there to see what's going to happen and how it's going to behave. That's going to tell us the most about the future risk of relapse and resistance. So this looks something like this. You have patients who come in as part of a standard practice anywhere, and instead of taking them immediately to the operating room and removing the cancer, that tumor would get whatever starting point is appropriate backbone therapy. We do a baseline biopsy, and then we look at the tissue, the tumor, when we remove it, or we repeat a biopsy and see exactly what happens to that, to know what is it going to look like now. And this may be a different tumor altogether. You may start with an orange and end up with an apple. You have to know what you are actually attacking and how it's evolving. We can get different predictors and new targets that way. And these, eventually, this is a relationship. It's not something that ends at the time of surgery. You continue to follow these patients and look at events in the future. You track them. You track their tumor in the blood. Circulating DNA is a big, important strategy to identify what risk of relapse and what new targets may happen. And that way, we can actually maintain a follow-up and large data on patients that we do and treat in practice. So this is logical, is that if you block one pathway and you think that you're getting away with things, you actually may de-repress another pathway. And you don't know that unless you're actually monitoring cancer, unless you actually have the cancer in place to restudy it once you do your backbone therapy. If you don't do that, then otherwise we'll be missing an opportunity, because these de-repressed pathways actually are new targets. And if they're new targets, then we can block these targets to enhance effect and delay resistance. But we have to actually look at the dynamic interaction of the tumor with the treatment to be able to design these new therapies. Otherwise, it's a blind process. So this is a little bit more dynamic than what we are used to. It's not something you remove and then you attack and think you got it made. It could be that you're blocking one pathway, dropping something down, and something else will come up. And actually, we should be prepared for the possibility that this may be more complicated. Remember multiplicity. There may be other pathways that may pop up down the road, so we have to maintain follow-up and a way to track patients to see what kinds of pathways will actually reappear or show up down the road. So right now, what we do is this. We treat patients. We overtreat the majority of patients. It's a problem. But we miss the ones who have the resistance issue. And what we keep doing is we keep flooding more and more, but we keep overtreating more and more, and we're still not catching the resistant disease subsets. What we need to be doing is doing a little bit more tailored therapy. So it wouldn't make sense to wear a suit that's oversized. You have to make it to size, right? So we have to tailor therapy to each patient and make treatment actually individualized. And even then, we may be over-treating some patients, but we shouldn't be over-treating by as much. Okay, that's very, very important. And the way I liken this is to peeling an orange. We really are not interested in the peel. So we want to remove the peel to see the core. What we do with preoperative therapy is that we actually remove the peel and discard it. If it goes away, why do we care much about it? We care about what's left. That's where the core problem is. And that's how we should think about breast cancer. And as we do this, because there's so many points of input, we have to be careful about what constitutes value for patients. Because value is not equal to only benefit of therapy. It's also dependent on cost, toxicity. So when you calculate value, you have to take into account how much negative does that treatment have, not that will only get rid of the cancer, but hurt the patient. So value is a very important concept to apply as we investigate all this. And I'm confident that there's a lot of ways to do things a lot more effectively. This is a picture of Petra, which some of you are probably aware of, Petra in Jordan, my home country. And 2,000 years ago, Petra was built in, carved in the face of the rock with very primitive tools and produced this amazing, beautiful city. And if people can do that 2,000 years ago with primitive tools, we can cure breast cancer this day and age with the tools we have. Thank you very much.
Well, thank you, Masarvi, for that stimulating talk. Another round of applause. So we'll move on to the second speaker for tonight. It's with a lot of pride and privilege. I introduce Dr. Vani Mantharam. She's a board-certified general surgeon at Stanford Healthcare ValleyCare. She's part of the University Medical Partners Medical Group. She's been practicing surgery for over 15 years. She's completed her general surgery training at UCSF Fresno and is a member of the American Society of Breast Surgeons as well as the American College of Surgeons. She stays busy outside of work with her two lovely children. Her introduction obviously just represents her. She is extremely modest, mild-mannered, but an amazing surgeon. So she's not only a great surgeon, a great colleague, but also a great friend. Vani, come on up.
Thank you, Rishi. That was very kind. Like Rishi was saying, I've been practicing here actually in Pleasanton for close to 8 years. I actually was practicing up in Washington State outside of Olympia. And interestingly, so I see a lot of breast cancer here in this area, but where I was outside of Olympia between Seattle and Portland has a fair number of breast cancer as well, kind of along that I-5 corridor. And the thought is that area doesn't get a lot of sunshine. So this area has breast cancer, I think, because of affluence, but there's kind of the opposite. So I don't only do breast surgery, but I have a special interest in breast surgery. I have a lot of patients who have breast cancer, unfortunately, and other benign diseases. So thank you for having me. First off, I was just going to talk a little bit about the background of breast cancer. I almost feel obsolete now. I shouldn't talk about surgery because maybe in the future we won't need to do surgery. But so what increases our risk of breast cancer, of getting breast cancer? So there's risk factors that we can change as individuals, and there's some risk factors that we can't change. So unfortunately, being overweight does increase the risk of breast cancer, not only breast cancer, but other cancers. Like I was saying earlier about affluence, also diet, when we have, unfortunately, more money, we eat better too, and so tend to eat higher fat foods, and also processed foods can increase our risk of cancers. Alcohol consumption, over 2 alcoholic beverages a day. The other thing is prolonged estrogen use. So I always ask women who aren't always aware, sometimes they'll, after menopause, be on Premarin or some type of estrogen for over 10 years, and they've never been told that maybe that was too long. So if that's somebody that sounds like you or somebody you know, maybe talk to your doctor about weaning off of those hormones. And actually, any women who've had children or in the future, the longer you breastfeed actually is a benefit. And the thought is over a few years for each child. So what are risk factors that we can't change? So every decade of life, our risk of breast cancer increases. And so the risk for an 80-year-old woman is higher than for a 40-year-old woman. Gender, being a woman, increases your risk obviously much more than a male, but men can still get breast cancer. It's not as common. So it is good to know if you have a partner or spouse, if they feel a breast lump, make sure they get medical attention as well. Probably in the 15 years I've been doing this, majority of my patients are women with breast cancer, but I have had maybe, 10 men that I've seen with breast cancer. So it's still, men can get breast cancer. Genetic history you can't change if you have a genetic marker such as BRCA gene, which we hear in the news. If you've had breast cancer in the past, so if the opposite side had a breast cancer, or even the same side, unfortunately, are increased risk of having cancer in the future. Other thing that we see more and more is early menarche, meaning your periods start at a younger age. So normally, girls start periods around 12, 13, but now we're seeing younger and younger girls starting periods. And we think it also is related to diet and being overweight. So unfortunately, something that can't be changed, and actually stopping periods later in life. So it leads to kind of a prolonged time of having periods can increase your risk of breast cancer. And nulliparity, meaning having no children at all, no pregnancies, can increase the risk. So why do we get mammograms? So I always hear this, my friend found his breast cancer and didn't get they didn't see it on the mammogram. Majority of breast cancers are seen on mammograms, so I always encourage women to get one. Now at ValleyCare we have 3D mammograms, so it's more slices of the breast can be seen, and actually I've seen recently very small cancers picked up by our radiology colleagues, so very beneficial to have that. I know recently in the news there was some talk about maybe changing the age of mammograms to older, but I unfortunately still see women in their breast cancer in the 40s, usually like over 45, so I would still recommend starting mammograms at 40, unless if there's a family history of somebody having it younger, then even starting younger. And then getting just an ultrasound or MRI doesn't replace just not getting a mammogram. So the combination of the tests are better than just having one test. So I also hear women are afraid, I don't want more tests, it's uncomfortable. So majority of women don't need more tests, meaning more mammogram, but more tests don't always mean more cancer. So about 10% of women who have mammograms need more tests. And so of those tests, 10% need a biopsy. So, and that's the other thing, you know, it's natural to be afraid, I'm getting a biopsy, I'm afraid have cancer, but the majority actually don't have cancer, maybe benign lesion or something that can be followed. So the majority do not actually show cancer. So what if you have a benign mass, something that you feel, or they see something abnormal on your mammogram, but it ends up being benign? It can be most of the time followed, but I always tell women, I mean, since this is a talk about breast surgery, if it's something that you're not comfortable with following, or you don't want to go back every 6 months, definitely talk to your doctor about getting a referral to a surgeon. Most surgeons are happy to remove it, and I do remove a fair amount just for anxiety. You don't want to go back every 6 months. And the good thing about having a benign breast mass can be done with a small scar and very little deformity and very little downtime. So what if you have a biopsy that shows cancer? Typically, I would say the treatment is surgical, although we heard that maybe in the future it may not be. But so normally what will happen is your regular doctor will send you to see a surgeon, but occasionally if the tumor is large or is more advanced, then a medical oncologist like Dr. Sani may also see you. So the other important thing is it does get very overwhelming when you get a diagnosis of cancer or somebody you know, and there are a lot of doctors involved. So just remember, it's a very the team approach, multidisciplinary approach. So there'll be a lot of doctors seeing you throughout the way. Initially, you'll have seen the radiologist who did your biopsy. He or she may talk to you about, you know, what's next. Your regular doctor will probably send you to see a surgeon, somebody like me. Medical oncologist is a different type of doctor in terms of they don't perform surgery, but they treat you medically, meaning if you need a chemotherapy or for something like tamoxifen. Radiation oncologist is actually a different type of doctor who administers radiation if you need that. And then we did mention Sherry earlier is a valuable, I don't know, probably if you've met her when you came in, Sherry's our nurse navigator. She's very helpful, and we're very fortunate here at ValleyCare to have her because she's basically a navigator. She'll help you, you know, through that overwhelming process. Where do I go next? Who do I see? Why am I seeing this doctor? And then sometimes you'll need a plastic surgeon, not always, but that doctor may also be on your team of doctors. So kind of things to know or kind of get some idea before you see the surgeon or even medical oncologist, kind of get a sense of what size is my cancer. And when you see the surgeon, ask what kind of surgery would you recommend and why. What are the risks and benefits of each procedure, and if you need to see the plastic surgeon. And a lot of times I know patients get overwhelmed, especially when they have cancer, so they kind of forget this stuff. So if you see a surgeon, if you don't ask these questions, they should automatically tell you these things. So I kind of broke down the types of surgery that we offer for breast cancer, and it hasn't really changed in the last 10 years, I would say. The two main types of surgeries are mastectomy, removing the whole breast, or lumpectomy, which we also call partial mastectomy. And I also added at the bottom about lymph node surgery, which is an addition to the breast surgery, which is the primary surgery. So I'll talk about those individually right now. So what is lumpectomy? We also call it partial mastectomy, and the reason we call it that rather than a lumpectomy is because when there's breast cancer, we don't want to only remove the cancer, we want to remove a rim of normal breast tissue to make sure we get adequate margins, which is basically the amount of tissue we take around the cancer. So if you choose to have lumpectomy, you would also need radiation. Most of the time, so I say most of the time because it really depends on your age and other factors. So now, why do we offer lumpectomy? So I would say maybe 20, 30 years ago, women, you probably know women even in your family or friends who've had mastectomy, radical mastectomies, which were very disfiguring. We find that now women don't need that for breast cancer because the long-term survival is the same as long as you get radiation along with the lumpectomy. So when you see the surgeon, that surgeon should always offer one either one and let you decide. Normally, what I would do is offer each one, but kind of guide you and say this might be the best alternative or option for you. So I would say the main benefits of lumpectomy is, so some women have anxiety over removing their whole breast. Some women have anxiety of not removing the whole breast. So some women who don't want a mastectomy, don't want to go through reconstruction, there's less anxiety with a lumpectomy. I'd say that would probably be the number one benefit of having a lumpectomy. Also, depending on your schedule, your work schedule, your family, you can go back to work sooner, take care of your family. Cosmetic outcome is very good, so nobody would ever know you had a lumpectomy, except maybe yourself. Nice thing is you preserve the natural breast. It feels the same. Again, it looks for the most part the same. And I would say most women that I see are early stage 1 breast cancer are good candidates for breast conservation. So what are the risks? I tell everyone this. Yes, there is some breast tissue left behind, or the majority of breast tissue is left behind, so there's always a chance that cancer can come back, but it can come back again in either breast because, again, once you've had breast cancer, you are at increased risk of getting cancer in the future. There is a scar on your breast. Some women notice a deformity. I would say more likely if you have a larger tumor relative to the breast size, rarely infection, and again, the loss of volume might be something that you and your partner are the only ones who notice it, maybe not anybody else. Sometimes I see a woman and I like to offer a lumpectomy for everybody, but sometimes I tell them, I don't think that you'd be able to have a lumpectomy. And there's certain situations, so what's called ductal carcinoma in situ is a precancerous lesion. So technically we treat it like cancer, but it doesn't spread. But the goal is to remove all of it so it doesn't keep growing. And so if you have extensive ductal carcinoma in situ, you might need a mastectomy. Again, a large tumor relative to the breast size, then just breast won't look the same. So I would say, you might need a mastectomy. If you've had breast cancer in the past and you've already had radiation, you might not be able to have radiation again to that same breast, so then you might need a mastectomy. The other thing I didn't add, but I'll kind of talk about later, is a genetic mutation. So if you have a genetic mutation like a BRCA gene, which is commonly known, there is an increased risk of having breast cancer in either breast. So some women in that situation choose to have a mastectomy. It really, again, is personal preference. Doesn't mean you automatically need a mastectomy. It doesn't mean 100% of women will get breast cancer, but that is an option. So the nice thing about lumpectomy scar, so I always tell women, where is their scar going to be? It's usually in the location of the tumor. Sometimes, especially if you're kind of worried about the scar, it can be hidden around the areola, so it can't be seen, or even in the inframammary fold, which is kind of the fold below the breast. So what are the sentinel lymph node biopsies? So if we do breast surgery, we also have to sample the lymph nodes, and the reason for that is we need to adequately stage the cancer. So what that means is when breast cancer spreads initially is the lymph nodes into the armpit, which is the axilla. And so normally we do that through a separate incision. And the day of surgery kind of is a long day, so I always warn women as well. But you get an injection of blue dye and radioactive tracer, and then I use those to kind of find those green things right there are your lymph nodes. And so kind of where that tracer goes into the lymph nodes. And if we sample the first draining lymph nodes, which are called the sentinel nodes, and there's no cancer there, then we don't worry that there's cancer elsewhere. Main risk, so I will say this part of the surgery tends to be more painful than the breast surgery itself. There is some swelling. Some women get kind of stiffness of the arm. Rarely, even with just sampling the 1 or 2 lymph nodes, can cause lymphedema. And that's basically permanent swelling of the arm. And so I always tell women, kind of be cognizant of that, avoid blood draws, IVs in that arm, even blood pressures. And then I'll try to have you see the physical therapist for exercises. Occasionally we'll have to do what's called a lymph node dissection. So if we go back to this picture, you see all these green things, those are all the lymph nodes in the armpit. So sentinel node, we usually remove anywhere from 1 to 3 or 4. Axillary lymph node dissection is actually removing anywhere from 5 to 20. I've seen sometimes lymph nodes in the armpit. And the reason we don't like to do that is because all those risks I was saying are increased, and the deformity is more, the recovery time is more, there's more pain. Increased risk of lymphedema, but occasionally I do have to do it if there's already, already proven cancer in the lymph nodes. Fortunately, it doesn't come up very often. So going on to mastectomy, what is a mastectomy? Basically, it's removing the entire breast, the nipple, the skin, the areola. It's important to remember that a mastectomy doesn't remove all of the breast tissue. There's still a small amount of breast tissue cells that are left behind underneath the skin. One of the advantages of mastectomy is normally if this tumor is less than about 3 centimeters, you would not need radiation. So that's one benefit. I will say some women prefer a mastectomy, so definitely that's a good option if you just don't want to worry about the breast tissue remaining. Sometimes, like I was saying, if it's a large cancer, I may recommend a mastectomy. Also, some women, unfortunately, have breast cancer not just in one area of the breast. So if you imagine the breast like a clock and there's different quadrants, if there's breast cancer in different quadrants of the breast, then maybe sometimes I'll offer or recommend a mastectomy. And then again, like I was saying, genetic mutation, there is a higher risk of getting breast cancer in the future. But again, it's not 100%. So I actually have had a few women who've had a BRCA mutation who choose not to have a mastectomy and just have close surveillance. So there's different types of mastectomies, and this really hasn't changed, I would say. But with a mastectomy, most women choose to have immediate reconstruction, so we try to leave some of the skin to make there's enough space to put an implant in, and that's what's called skin sparing. I'll talk a little bit about nipple sparing, which is basically leaving the nipple in the areola. And then plastic surgeon would perform immediate or delayed reconstruction. So that's another thing that's confusing. If you have breast surgery, you have a mastectomy, you usually need 2 surgeons, a general surgeon like me and a plastic surgeon to do the reconstruction. And they would usually talk to you about implant versus tissue-based reconstruction. With a mastectomy, you would still need the sampling of the lymph nodes, like I was telling you earlier about the sentinel nodes, because we still need to stage the cancer. Fortunately, so the downside, there is more pain still, but the upside is sometimes it can be sampled through the same incision, so you don't have to have a separate incision. Benefit is, again, some women just would feel better about having the whole breast, so definitely alleviates anxiety. Again, there's a significant reduction of the amount of breast tissue left behind, but it's not zero. There's no way to remove all the breast tissue. So there's still a small chance of having a little bit of breast tissue left behind. What are the risks? So the main thing I always tell women is there is more recovery time, more discomfort. Some women get kind of phantom pain and numbness, kind of chronic numbness of the chest wall. Rarely there's there are more complications that can occur after a mastectomy, meaning things that you might have to go back to surgery for, such as the skin may end up dying a little bit, or there may be bleeding. Again, because some of the breast tissue is left behind, I always tell women, even after mastectomy, we encourage self-breast exams, but even to examine the chest wall that's left behind to feel for any little lumps or anything that looks unusual, because women can get recurrent chest wall cancer. Some women, the unfortunate thing is, the anxiety can go either way. Some women just say, I want a mastectomy no matter what. Some women, they have to have a mastectomy because of the reasons I was talking about earlier, and that makes them very nervous, because they just feel like their body is disfigured. And so obviously that's one of the risks. The other thing is the sensation is not the same, so that's something to remember. So what bilateral mastectomy, what is that? So let's say a woman has a breast cancer on one side, but they say, I want my other breast removed. That's what's considered bilateral mastectomy. Some women, unfortunately, present with breast cancer on both sides. So sometimes we do it for that, but that doesn't necessarily mean they need a mastectomy. Why do we hear about this more in the news that women are asking? I think because, we hear celebrities have these mutations, getting good results with bilateral mastectomy. I even see women with very small stage 1 cancers would be really good candidates for breast conservation. They want a mastectomy. So it's important to remember the risks, I think, for mastectomy, like I was saying, are much more than a lumpectomy. So I always kind of reiterate that, because I don't think women realize until after they've had surgery that, this is a longer recovery time. But really, without a genetic marker, there's little benefit to having a prophylactic mastectomy, meaning it doesn't increase your survival. just because you have a mastectomy doesn't mean you're not going to get breast cancer again, unfortunately, and have it come back. So, and the majority of the times, the risks outweigh the benefits. So it's something to remember, but definitely we can do that if that's something that you would like. What is nipple-sparing mastectomy? This is a good option. So if a woman has breast cancer, it's not right underneath the nipple. It's a very good option. The other thing is, if you're having a mastectomy for prophylaxis, meaning there's no cancer, it's very good. So what it is basically the nipple, we treat it more like the skin and we leave it behind. So we find that the recurrence rate for breast cancer coming back is the same for just a plain mastectomy with removing the nipple. So that's why it's still, that's why we offer it. Sometimes the surgeon may say, you know, you might not be a good candidate. If you have a lot of scars around the areola, if you've had radiation before, depending on the size of the breast, or if the breast is very basically hanging, the blood supply is what we worry about for the nipple. So if we worry that the blood supply might not be there after nipple-sparing mastectomy, we tend not to offer it. The nice thing about nipple, or I don't know if I'm talking about it. The nice thing about nipple-sparing mastectomy is the scars also can be hidden in the inframammary fold. So basically, if you're wearing something low cut, you won't see the scars and nobody would really know. Downsides of nipple-sparing mastectomy, it's important to remember, I would say the majority of women, the nipple doesn't feel the same. There may not be sensation. It may not look the same either. And then occasionally a small percentage, the nipple doesn't survive, so that means more surgery to remove the nipple. So I was just going to close up with, you know, I've been doing this so long, I hear a lot of the same questions, and I know when you come to the office, you forget to ask these, or you may bring these up, or forget that we talked about it, but I think I kind of briefly talked about this. What are these? These are some concerns I hear. I hear women say, you know, I want a mastectomy, I don't want to die from breast cancer. Kind of like what I was saying, just because you have the whole breast removed doesn't mean that cancer won't come back, doesn't mean cancer is not in the lymph nodes. Really, it's a multidisciplinary approach. We want to know, is the cancer in the lymph nodes? Those are the kinds of factors. Is it estrogen, progesterone receptor positive? Those kind of factors are what will make us, what we'll kind of know, what we'll know, what the information we need to know is if this is going to come back. So mastectomy is kind of a separate thing. Some women say, I don't want surgery because I don't want you to cut into it because I've heard that can spread the cancer. That's not true. It's the same with a biopsy. Women get afraid, you know, I don't want a needle biopsy. I don't want the radiologist to do that because if I have cancer, I don't want to spread. That's not true. This is another concern I hear. So I want surgery, but I don't want any other treatment. Again, like I was saying earlier, that breast cancer treatment is really multidisciplinary. So if you just have surgery, but you don't have radiation, or you don't have chemotherapy if it's recommended, or you don't have anti-estrogen if it's recommended, then your outcome may not be as good. So I really recommend, you know, I defer to my medical oncology and radiation oncology colleagues. If they say this is what you need, then I would say definitely do that. Should I get a second opinion? I definitely encourage that. Like I said, I don't only do breast surgery, I do other surgery too. So I know there's surgeons who only do focus on breast surgery. So I will say, and I'll tell women this, that stage 1 breast cancer is not, you probably won't get much differing, or even stage 2 differing options, surgical options, but definitely if it makes you feel better, you're not going to hurt the surgeon's feelings by going elsewhere. So it's definitely, I would say, always recommended if that's something what you would like. And then also, if you, in the future, if you ever have to see a surgeon, what's the best way to prepare for an appointment? I see women who come to the appointment, they don't have anybody with them, they're by themselves. It's nice to bring a friend or family member because it's overwhelming, you don't remember everything we talked about. And you'd be surprised, ask others, your friends or family members, what they've been through. They may have been through something similar. Don't use Google as your doctor because I find that like the story I said earlier about, you know, my mammogram didn't pick anything up, I'm the one who felt breast cancer. You hear these worst case scenarios, which is very uncommon, and the common things are stage 1 breast cancer that can be treated, curable, outcomes are very good. So there are legitimate breast cancer websites that I recommend, but, you know, Googling these blogs and things like that maybe aren't the best thing. And like I was saying earlier, find out your stage, if possible, the size of the cancer, then you can ask pertinent questions. And then if you go, let's say you had your mammograms done at ValleyCare, but you're seeing a surgeon elsewhere, it's nice if you get your films on disc and all the reports, because when you see the surgeon, and same thing if you come to see me, but you had your films elsewhere, it's nice if you bring them because I can look at them, because we're not all linked into the same system. Thank you.
Thank you so much, Vani. And if you're looking for a second opinion, please see Dr. Mantharam. I've worked with her for 8 years now, and I highly vouch for her. So we'll move on to some question and answer session. So.
Hello, Dr. Masawat. I have a few questions to you. I enjoy your talk very much. The first one is about the oncotype usage. Would you recommend oncotype usage on all estrogen receptor positive patients? And the second one is about the assessment of the cancer during the adjuvant chemotherapy. What type of images are you recommend to use for assessment of the tumor during the treatment? And the third question is about the preoperative adjuvant therapy. You say that you want to test the tumor response. Will you use endocrine therapy as a preoperative adjuvant therapy, or use chemotherapy instead?
Yeah, great questions. Can you hear me? Is this working?
Yeah.
So I'll start from the back. Last question. So yeah, endocrine therapy in postmenopausal women, the use of an aromatase inhibitor is a standard neoadjuvant therapy for ER-positive breast cancer. So it doesn't have to be chemotherapy. And in fact, chemotherapy, if you look at the data comparing the use of neoadjuvant chemotherapy versus neoadjuvant aromatase inhibitor therapy in postmenopausal women, the response rates are the same, but the rate of breast conservation is higher with anti-estrogen therapy, with an aromatase inhibitor, and the chances of pathologic complete response are exactly the same too. So there is really no advantage to using chemo over an aromatase inhibitor for neoadjuvant therapy in an ER-positive postmenopausal cancer. I think of oncotype, I'm just going to go back to the first question now. Oncotype analysis, there's more and more data that support its use for two objectives. One is the ability to predict benefit from chemotherapy in some patients, so it has a predictive power. And two, it has a prognostic power, which is what I showed you today, is that this, regardless of what kind of chemotherapy you take, it tells you what to expect in terms of outcome from the cancer, and it can isolate cancer that has poor prognosis that needs to be studied separately. For chemotherapy use, I tend to look at it also by menopausal status, because I didn't go through this. I actually had wanted to kind of elaborate a little bit more about how chemotherapy might work in some patients and why it might not work with other patients. Chemotherapy, one of the biggest things that it does is that it can induce ovarian suppression, ovarian ablation. It can shut down the ovaries. And if you look at data for benefit from chemotherapy in ER-positive breast cancer, it is triple the amount of benefit in women who are less than age 50 versus women who are older than age 50, past menopause. Chemotherapy benefit is a lot less. You don't get as much bang for your buck. So I think there's going to be a lot of separation and more data coming out about where and how to use chemotherapy for ER-positive breast cancer, but it's going to be for fewer and fewer patients. And as for the second question, for adjuvant therapy, a follow-up, and I think this is a very important question because it comes up all the time. We do not recommend anything beyond clinical follow-up and mammograms for remaining breast tissue. No imaging, no biomarkers in the blood, no tumor markers. The American Society of Clinical Oncology recommends against doing that, and we do not do it in our practice. Once we finish adjuvant therapy, we follow patients clinically and do breast imaging according to guidelines. And if there are symptoms suspicious for disease recurrence, then we do imaging or look for cancer recurrence. But if you think about it, because recurrence is mainly systemic, it's other than doing breast imaging, if you look at recurrence outside the breast, that becomes stage 4 disease, and there's no real early detection of stage 4 disease. It's an oxymoron. So we do not recommend doing any routine imaging with all what's associated with them in terms of radiation exposure, cost, anxiety. So we do not do routine imaging after adjuvant therapy other than breast imaging. Yes, hopefully that answers the question.
Yeah. Any other questions?
You're hitting some really passionate points of mine. So if I talk too much, let me know. I can stop and slow down a little bit.
No, this is helpful.
Hi, just a quick question from an extreme layman. I hear a lot about immunotherapy on TV. Where does that fall into the treatment scope?
So immune therapy is a very clear advance in the treatment of cancer, and Nobel Prize went to Dr. Allison and MD Anderson, who began the work on CHEK2 inhibitors, which is very exciting actually to see. In breast cancer right now, there are ongoing clinical trials. There is definitely a role in lung cancer, melanoma, and certain other types of cancer that are ahead. There's no clear benefit or established role in breast cancer. The biggest promise is in triple-negative breast cancer in the future. We don't know what the data will show. It is something that we will find out. Hopefully in the next couple of years we'll have more data. There may be some role in ER-positive breast cancer. Actually, the most famous paper that came out was a single patient that was treated at the NCI with Dr. Rosenberg, and they did an elaborate immune therapy protocol, not just the drugs, but also collected cells, CAR T cells type therapy. And a patient with metastatic ER-positive breast cancer had complete disappearance of all cancer. But that was one patient, and there were 14 patients in that study. They only reported the one, so they didn't tell us about the others. So this is something that we will see how it evolves in the next few years, hopefully.
I actually have a surgical question for Dr. Mantha.
I was going to have a question too.
Go ahead.
So if I have a patient who has a very small, well-differentiated invasive cancer, ER/PR positive, should I do an oncotype? That's what I'm going to get questions now.
Great question. So sometimes you can tell by pathologic criteria if the cancer is going to be benign, let's say, called benign.
Yeah.
So low grade, low proliferation, strongly ER/PR positive cancer. And you don't really need to do a $3,000 test to find out that there's going to be something different. It's almost always congruent. Sometimes you'll have a surprise, but there usually is something off about the tumor markers. Maybe the progesterone receptor is absent, maybe proliferation is higher, but grade and proliferation, strong ER/PR, should be more telling. You don't have to do oncotype in every patient. And sometimes, if you know you're not going to use chemotherapy, because we do this for a predictive ability to tell you about chemotherapy benefit. If we know we're not going to use chemotherapy, if there's a lot of competing risk of mortality or morbidity, if this is a very old patient or a patient who does not want to take chemotherapy, there's really no logic to doing an oncotype.
Good, thank you.
So, Vani, my question was, I think your slides touched upon it, but I think this is something that we get asked by patients all the time. If you're able to elaborate, you talked about most of the lumps actually found tend to be benign, most of the biopsies actually tend to be benign, not cancerous. I think the knee-jerk reaction or the emotional reaction to an abnormal mammogram or any biopsy is, I just want the breast operated upon. Can you enlighten us on, based upon benign versus non-invasive or DCIS versus invasive cancer, how patients can stratify their approach and be comfortable with doing less.
So if I see technically like a benign mass might be something like a fibroadenoma, which is a firm benign mass. They can grow, cause discomfort. If they're growing and causing discomfort, I say, you know, consider having it removed. Sometimes a biopsy will say normal breast tissue. Then we worry. I even worry, you know, I know, yeah, I don't want you to worry, but I worry that there's something maybe that was missed on the biopsy. I would recommend surgery. Then we have kind of in between what's called atypia, which are abnormal cells that we find on biopsy. Then I would also recommend surgery. So, you know, sometimes there's truly benign masses, you know, benign cyst. Like I said, fibroadenoma. If they're truly benign, they don't need surgery unless you absolutely want them.
Thank you.
I want them removed. Yeah.
Thank you. So Dr. Masarwe will be actually leaving us. He has a long drive back. So if you can give a round of applause for both of our panelists.
Thank you so much. Very nice to be here.
So I think we'll continue on to the second part of our program. It's with great pleasure that I introduce you to Dr. Jeff McDavitt. He's a pathologist with the California Pathology Medical Group at Stanford Healthcare ValleyCare. Dr. McDavitt did his residency and general surgical pathology fellowship at the University of Southern California Keck School of Medicine. This was followed by an additional fellowship at the University of Pittsburgh in bone and soft tissue pathology. Prior to working at ValleyCare since 2015, he was actually the chairman of the Department of Pathology at St. Joseph's Medical Center in Stockton. He's always had a special interest in breast pathology. We are very lucky that he chose to come to us in 2015. Having had the privilege of working with him, our breast pathology has become significantly elevated with his efforts, such that actually on September 26th, we went through our Breast Cancer Center of Excellence accreditation, and it's all a credit to him that actually we got a commendation for our pathology at our center. He's not only, again, a great pathologist, very unassuming, great pathologist, great colleague, and a great friend. Jeff, come on up.
Great. All right. Thank you. Good evening, everyone. Thank you, Dr. Sahani, for hosting such a wonderful community event. And I echo his thanks to everybody who worked to put on this event. I know a lot of work and effort goes into it. So thank you very much. Denise, Lee, and Sherry as well. I'm going to be talking about the new 8th edition of the AJCC cancer staging system for breast cancer, which is actually, this year is actually quite exciting because it's using biomarkers, which we've already heard about tonight, such as ER, PR, HER2, and Oncotype DX into the staging system. So it's pretty exciting. And just basically the outline for the talk. I know there's a wide variety of medical knowledge in the audience tonight, so we're going to define what tumor staging is. We'll look at the different components and discuss which prognostic factors are actually in the new staging system. And then we'll look at some of the new tables. Just be forewarned, they are as medicine evolves, things get more complex. The tables are pretty complex, but we'll go through it step by step so you can get an appreciation to that. And then finally, we'll wrap up with some patient examples to see how the new staging system can affect patients pretty vastly. So let's just start out by asking, what is breast cancer staging? So it's the process by which the amount of tumor in the body is determined. And it includes the primary location. So in this particular instance, we're talking about breast cancer. So breast would be the primary location. And then it also incorporates spread, whether it's regional spread or distant spread. So regional spread would be axillary lymph nodes. Distant spread would be, did the tumor metastasize to the liver, to the brain? So all those are incorporated into the different staging components. And it gives you an overall severity of the tumor. And it also helps physicians communicate with one another so that they're all on the same page about the treatment strategy. And it also identifies patients that could be eligible for different clinical trials. So it really has a wide range of uses. And so there's different types of staging. Just briefly, clinical staging is based more on the physical exam or radiology. So can the physician palpate a certain tumor size? Does radiology pick up something, some metastasis somewhere in the body? So that's the clinical stage. And then what we're going to focus on today is the anatomic stage, which is the classic stage, which we'll go through. And then the new prognostic pathologic stage, which is very exciting because this is the first organ system that actually incorporates the prognostic markers into the staging. And the pathologic stage, or the anatomic stage, basically incorporates information from the pathology specimen, so the excision specimen. In this case, it'd be a lumpectomy specimen or mastectomy specimen. And then there's also post-therapy staging. So we talked a little bit about post-therapy treatment and everything. So you'd be restaged potentially after therapy. And then again, restaging if you had a complete response and then the tumor was to recur, sometimes up to 10 years later, you'd have restaging. But this talk will focus on the anatomic stage, and then a subcategory of that would be the pathologic prognostic stage. So before we look into the new tables, it's important for those of you that don't have any background on the staging, just the different components. So when we go through the tables, you can have some idea about how the movement goes along with the different stages. So the American Joint Committee on Cancer is the body that governs and implements the staging system, and it's the TNM staging system. So the T is basically going to describe the primary tumor, and that's basically size-based. So different sizes will have different T stages. The N stage refers to, or the N category refers to the regional lymph node metastasis, and M category if there's any distant metastasis. So just briefly, in the T category, we'll have the TIS, which is in situ carcinoma, so it hasn't invaded yet. So that's non-invasive. And then T1 lesion is less than or equal to 2 centimeters. And then as you go higher up, T2, T3, T4, you can see that it is increasing in size. And T4 is any size, but it has extension to the chest wall or skin. And same kind of format here with the N category and M category. N0 would be no regional metastasis, and N1, 2, and 3, you can see that there's increasing number of lymph nodes that are positive. And then M category, again, any distant metastasis. So when you put all of those together, that's how you're going to get your stage, and that's what we're going to be talking about tonight. And you can see the different combinations of the T, N, and M gives you a different stage. So it's no surprise, T1 would be a small tumor, and then if there's no regional metastasis, there's no distant metastasis, you're going to be a low stage. So good prognosis, so you'd be a stage 1A. And as you go up in stage, you're going to have a more aggressive tumor. And finally, stage 4 is any distant metastasis. And as you increase your stage, there's about a 5% decreased overall patient survival, 5-year survival. And so the new pathologic prognostic staging system is going to incorporate histologic grade. So if it's well differentiated, moderately differentiated, or poorly differentiated, HER2 positivity or negativity, ER, PR expression, and also multi-gene panels, which we've heard about, the Oncotype DX, which is different copies, different numbers of genes that get expressed, and then it comes out with a score, low risk, or intermediate, or high risk. So, and one of the things is that one of the things that's exciting is that doctors have known for some time that all of these things play a role. Obviously, a poorly differentiated tumor on histology makes sense. It's going to behave more aggressively, but those were never incorporated into the staging system, but now they are. These are some of the ones that were picked because it's pretty basic for a pathology report. I mean, all of these things should be in there as standard of care, with the exception of potentially a multi-gene panel. Oncotype might be indicated, might not be, but all these other categories are part of the standard report. And also, these have reasonable standardization, so we have guidelines on scoring that's standardized amongst all pathologists that are interpreting the results. And probably the most important thing is that the pathologic prognostic stage, it's going to assume that the treating physician treats with the best medical care and appropriate medical care possible. So if they're not going to get treatment, then the prognostic stage doesn't matter, because that's what it's based on. So, but luckily here in the United States, most patients are able to get that care. So we'll go just briefly, because I do have some slides that talk about grade. So this is how the pathologist will grade the breast cancer. So we have a Nottingham score, and there's different components. So you'll have your tubule differentiation, nuclear pleomorphism, and mitotic rate. And when you have a tumor that's composed mostly of tubules, it's well differentiated, you get a score 1, and then the less tubules you have, you get a score 3, so the higher you go. Same thing with nuclear pleomorphism. Score 1 is going to be nice and round tumor cells, and then score 3, you're going to have more pleomorphic, more malignant looking tumor cells, and then same thing, mitotic rate is a component. So you add up all these scores, and then you'll get a grade. So grade 1 would be well differentiated, grade 2 would be moderately differentiated, and grade 3 is poorly differentiated. So this is just an example. So you can kind of see the image, and it might help when we're looking at the tables later. So this is an example of a well-differentiated tumor. Gets a score 1 for tubule formation. So you have these nice, well-formed tubules, and they're infiltrating into breast stroma. So that would be a score 1, and then opposed to that is a score 3. So this particular breast cancer has no tubule formation, and it's poorly differentiated in terms of the tubule score. So just looking at this, you can kind of see how this one might behave a little bit less aggressively, and then this tumor might be a little bit more aggressive. And just an example of the nuclei, these are nice round and regular nuclei, so that would be a grade 1 nucleus. And the opposite extreme of that is a grade 3 nucleus. So you have these very irregular, malignant looking tumor cells. And so besides the actual grade of the tumor, the other aspects in the prognostic staging is ER and PR results. They make it pretty easy. Less than or greater than or equal to 1% is going to be positive for both ER and PR. HER2 by immunohistochemical technique is going to be a 3+, is considered positive. And a FISH study, if it's positive, would also be accepted. Equivocal cases of HER2 are considered negative for the staging purpose. And multi-gene panels, and there was some discussion, but these are generally offered for ER/PR positive, HER2 negative, lymph node negative patients. So these would be your stage 1 and 2A tumors. And the interesting thing here is that for these stages, stage 1 and 2A, if the oncotype DX is a low risk, then it automatically bumps you down to stage 1A, regardless of grade. So even if you had a poorly differentiated histology, which we saw, if the oncotype is low risk, then you'll be automatically down to a stage 1A. And it's estimated the new prognostic staging moves about 40% of patients to a different stage. And again, just some pictures so you can kind of get a better understanding when we say HER2 negative, HER2 positive. So this is a HER2 stain, and you can see that it's weakly staining, incomplete, and that would be considered 1+ stain, which is negative. And then on the opposite side of the spectrum, this is HER2 positive. So you're going to see this very bright membrane staining for a positive result. And this is immunohistochemistry. And same thing for ER. This is an ER positive tumor. You can see it's a nuclear stain, so that's why it's highlighting the actual round nuclei there. And so now, hopefully you can see those. I know it's small, but if you've had a couple glasses of wine, it might be a little more difficult to see. But these are the new prognostic staging tables. So when you are staging a patient, you'll have the pathology report. You'll have a table similar to this, and you'll fill out what the grade is, what the ER status is, what the PR status is, what the HER2 status is, if there's a oncotype DX or some type of multi-gene panel. That information will be on the first sheet, and then you'll go to this table. And so in this column here, these combinations of the T, N, and M, those are going to be corresponding to the anatomic stage. So I've listed these as stage 1A. A T1, N0, M0 is going to be a stage 1A. And then these combinations are stage 1B. So this is referring to the lower stages. And then in this column, this is where you'll find your grade. And then the HER2 status is in this category, so it's either positive or negative. And same thing with ER and PR, it's either positive or negative. And then in this column, it'll give you the pathologic prognostic stage. And so I wanted to just go over some kind of basic trends for these different stages, just to get, can't memorize this, but you can see certain trends on these tables. So in this particular stage 1A and 1B, the movement is really to a 1A. You can't get bumped up to a 2, stage 2, which we'll see in other stages. You can get bumped up a stage. And then you'll see that there's only 2 instances where if you're a 1B, you'll stay at a 1B, or if you're a 1A, you could actually not be bumped up to a stage 2, but you could go from a 1A to a 1B. And in that particular case, no surprise, you're triple negative, which is a poor prognosis. That's where you're going to see the movement. And also the grade, it's kind of an example where the grade comes into play. So there's multiple things going on to determine the final stage. So if you look at your grade 2, triple negatives, you're going to be right here. And if you were a stage 1A, but you're a grade 2 and a triple negative, you're going to end up at a little bit of a worse stage, 1B. And the same thing holds with grade 3, triple negative, also 1B. But one of the interesting things is for the well-differentiated tumors, this is an example where the grade does come into play and is important because the triple negative tumor that's a grade 1, well differentiated, you'll stay at a stage 1A. And now this is the table for the stage 2A. And basically on this stage 2A with the new prognostic stage, you can remain at a 2A or you can drop down a stage. So you see some of these categories are still 2A, whereas others go to a 1A or a 1B. Triple negatives will remain at a 2A. So here's your, for instance, a grade 1 tumor that's triple negative. You'll stay at a 2A. And that's independent of grade. So even if you're a poorly differentiated or a grade 3 tumor, you're still going to stay at a 2A. Triple positives will go to a 1A, regardless of grade, so grade's independent. And then you can see how complex it gets because if you look at the ER-PR positive patients with HER2 that's negative, the grade will play a part. So the grade 1 and grade 2 tumors that are HER2 negative but ER-PR positive, that's actually going to drop you down to a stage 1A. So there's quite a bit of movement here. And then stage 2B tumors, that actually seems to be, at least to me, kind of the most movement. So you can go down to stage 1, or you can actually get bumped up to a stage 3. So this stage 2B seems to have kind of the most movement. So for instance, stage 2B, which is the old, or the anatomic stage, if it's poorly differentiated histologically and a triple negative, that's going to bump you up to a stage 3A, so pretty significant. However, you can go down a stage as well. So the well-differentiated or grade 1 tumor that's ER-PR positive is going to go to a 1A. So this just kind of gives you an example of the different kind of movement that you can see. And then stage 3A actually has some pretty dramatic movement as well. You can see if it's a well-differentiated or grade 1 tumor that's ER-PR positive, regardless of HER2 status, that's going to move you to a stage 1B. And for stage 3B and 3C, there's not too much movement. The best is really down to a stage 3A, and that would be your ER-PR positives, grade 1 and grade 2. So for instance, here's a grade 2 and ER-PR positive, so that'll get you down to a stage 3A, and that's independent of the HER2 status. And then, importantly, stage 4 tumors, which is any type of distant metastasis, the prognostic factors don't come into play at all. So if you're stage 4, you're still stage 4 regardless of your biomarkers. And then we already touched on this, but this is for the Oncotype DX score. So if you're a low risk result, and then you're going to be automatically down to a 1A tumor or stage. Sorry. And so I thought I would end just to do a couple case examples of patients, just to see how the prognostic stage is going to change based on the biomarkers. So this is a 53-year-old woman with a 5.5 centimeter mass, and she had a biopsy which showed invasive ductal carcinoma. ER-PR were positive. HER2 was equivocal at 2+, so that's considered negative. And then her FISH study for HER2 was also negative. And she underwent lumpectomy with a sentinel lymph node. And this tumor is a well-differentiated tumor. Again, there's nice tubules, and this would be grade 1. And so based on her size of 5.5 centimeters, it's a T3, sentinel node was negative, so N0, and then there's no evidence of distant metastasis, so M0. So that would be an anatomic stage 2B. And when you go to the chart, she had a well-differentiated tumor, and then HER2 was negative, but ER or PR were positive. So then now, instead of being a 2B, she's going to be a 1A, which is pretty significant. And let's see. So this basically, this kind of summarizes the whole case there. So she dropped from 2B down to a 1A. And then for this other case example, this is a 45-year-old woman with a 2.4 centimeter tumor mass, and the biopsy again showed invasive ductal carcinoma, ER/PR negative, and HER2 also was negative, and she had a lumpectomy with sentinel node. And this lumpectomy confirmed a 2.4 centimeter tumor mass, and you can see that it is poorly differentiated on histology. So this would actually likely be a score 9 out of 9, so poorly differentiated grade 3 tumor. And she had a positive sentinel lymph node. So here is the normal lymph node, this kind of dark purple blue, and then this is just adipose tissue that's sometimes seen in lymph nodes. You can get fatty infiltration. But here's the metastatic tumor. This is the capsule to the lymph node, and then underneath it you can see here's the metastatic tumor. And just an immunostain that highlights the tumor. So again, this would be an anatomic 2B, same as the last patient, a T2 N1 patient. However, given the triple negative and the poor histology, the anatomic stage was a 2B, and then if you go here to the grade 3 category, and then a triple negative, this patient is going to be a 2B. So these two examples really demonstrate how the biomarkers really play a role, because we had two patients that anatomically were a 2B, and then they had much different pathologic prognostic stages. In summary, this is the first instance where biomarkers are being utilized in the staging of cancer. So the staging system, the TNM system would apply to colon cancer or pancreatic cancer, but breast cancer is the first instance where we're using biomarkers to give a prognostic stage. And so you can go up and down in movement of the stage, and it seems that the anatomic stage 2B kind of has the most movement with the biomarker results. And a similar or same anatomic stage can have a much different pathologic prognostic stage, which is what we saw with the two examples. And again, the most important thing is that the pathologic prognostic stage is going to assume that they get treatment based on their prognostic markers. And other cancer sites are on the horizon for this. It's not going to just stop at breast, so other cancer sites are going to be going to this. This is actually, the implementation of the biomarkers for breast cancer has been in the works for many years, but it was just last year that they were able to gather enough solid evidence to bring it out into the new staging. But it doesn't stop just at breast, it'll go for other cancer sites as well, and then there'll most likely be more biomarkers that come in future editions of the AJCC. So that concludes my talk. Any questions? Or?
Well, thank you, Jeff, for that great talk.
Well, it was very interesting, but I do have a question. Is the oncotype only for ER and PR positive cancer, or can be used for triple negative as well?
Probably the medical oncologists would probably be better suited to answer that, but I think it's basically for ER/PR HER2 negative, node negative patients, but the clinical situation could always be where they need to order it.
Yeah, so I think, like Dr. McDavid said, like Dr. Masavre talked about it, so it's only for estrogen receptor, progesterone receptor
Okay.
positive, HER2 negative, small tumors that are lymph node negative. So that's kind of the indication currently.
Okay, and the other quick question I have, are biopsies saved for future analyzation or as things come along that they find that's new, for example?
Oh yeah, great question. Yeah, so, well, first let me say if any of you have ever had a biopsy or surgery, you don't see us as pathologists, but it's a privilege to deal with your tissue and to take care of it and to give you the diagnosis. And having said that, we do keep the tissue it's in a paraffin block. We put the tissue in these about 2 centimeter by 1 centimeter blocks, and then that's how we make our slides. So the tissue is embedded in there, and then we keep it for at least 10 years. So sometimes if years go by and there's a new drug out there or a new molecular test, we have tissue that's formalin fixed, paraffin embedded that we do have available. So at least 10 years. Yeah.
Thank you.
Thank you.
I would like to ask about the HER2 test. Do we need to perform the FISH test on all cases or just the HER2 negative 1+2+, or we do FISH on every case?
Yeah. So there's not really a right answer to that. It's based on institutions, based on preference. Some institutions or physicians will just go straight to the FISH. Probably the more cost-effective way is just to do the IHC first, and if it's a 2+, then you reflex to the FISH test. But either way is acceptable. It's all within the standard of care if they want to do a FISH test. And then there's other means to do the HER2 testing as well. But those are the two main types. But typically people do the IHC first because it's a easier stain and it's less expensive. But either way is within the standard of care.
Hi, for a patient that had a second pathology report and it would show a PCR, can you enlighten us about the second pathology report after treatment?
Oh, right. Okay, so PCR would be pathologic complete response. So in that particular case, where surgery wasn't indicated, they did neoadjuvant chemotherapy. And then the pathologist will get the excision specimen, and then the standard of care is to submit the entire tumor bed. And then we look at each slide within that. So if the tumor bed is, say, 2 centimeters, that might be 8 cassettes. And then we look at all 8 slides. And then if there's no residual tumor at all, anywhere, then that's considered a pathologic complete response. But the key is you have to submit the entire tumor bed to know that. It's not like a lot of pathology, when you gross it, it's representative sections, and there's certain, based on the size of the tumor, there's certain amounts that are the standard of care to put in to represent the tumor. But in this particular case, the standard of care is to put the entire tumor bed in. So that would be what a pathologic complete response is. You see absolutely no tumor. You see tumor bed evidence under the microscope, but you see no residual tumor at all. Does that answer your question? Yeah. You would get a different
Stage reclassification.
Y. Yeah, there'd be a prefix with a Y, and then you would it'd be a T0. Yeah.
As a final sort of conclusion, I think we've had a great evening tonight with great speakers. I think our program has always been sort of very patient-centric, and we've built this program sort of around our patients. So I want to end the night by actually asking any breast cancer patients, survivors, family members, anybody who's been affected by breast cancer to stand up so that we can recognize you. You're the reason why we come to work. You're the reason why we do events like this, and this is what it is all about. So thank you, everyone. Thank you very much, and have a great evening. Bye-bye.